welcome to today's EULAR TV Scientific Digest. My name's Chris Wincup. I'm a rheumatologist at King's College Hospital in London. I'm delighted to be joined by Dr. Ed Vital from Leeds. Thank you very much for joining me today. You've just given a talk at the conference on joint disease in lupus. Why do you think that kind of talk is important, and why is it important that we as rheumatologists think about joints in lupus?
Yeah, I think this is an understudied area. So if you go to any of the lupus sessions at this meeting, people will be saying things like, we need better trials, we need more therapies, we need better treatment algorithms, should we treat to target, et cetera, et cetera. And when you look at any of those studies, it's very clear that you're not going to be able to achieve any of that unless we really know how to assess and treat musculoskeletal manifestations. They're so common in these cohorts. And when I started working in lupus a few years ago, we noticed that the literature on musculoskeletal disease is remarkably scarce, that there are some imaging studies, but not that many of them, and there isn't much else going back for many years. And that's why we, in my group, started working on it a few years ago, which I did with Ahmed Zayed and Khaled Mahmood, and we set up some studies, and we realized there was something useful here and built some momentum for it. So it was very nice that EULAR organized that session where there were a couple of speakers both talking about musculoskeletal lupus, summarizing it and trying to bring some forward momentum to it.
So I think often, as seeing patients in clinic with joint pain, it can be slightly difficult to assess the burden of either arthralgia or arthritis in patients. So it's interesting that you've done this imaging studies.
Yeah.
How prevalent would you say these symptoms are?
Yeah, there's two related observations there. One is that when you look at stuff about clinical impact of musculoskeletal disease, it's obviously really high. It's one of the highest things. So, for example, if you do a study where you ask patients, what's your worst symptom? Number one is fatigue, but then like 1% below that is pain and musculoskeletal features. And then if you look at things like work disability, again, it's completely dominated by MSK disease. So we're clearly not treating it well enough. And then you take all the imaging data that says, actually, we also really underestimate the amount of inflammation that's there. There seems like there's quite a clear message there, which is that we need to detect more of the active inflammation than we currently do and treat it with the therapies we have. We've got good therapies now. We just need to use them right.
I think it's interesting you talk about the newer therapies, but one of your slides did show some perhaps more conventional DMARD therapies from previous studies like the EXPLORER study. So in terms of those more conventional DMARDs, what's the story there? What's good for treating joint?
Yeah, so if you ask anyone, and I do this when I'm talking at workshops and things, and you sort of say to people, okay, you've got a lupus patient, their main problem is synovitis, what do you use? Absolutely everyone will say methotrexate. And when you say, okay, but in lupus, we also use azathioprine and mycophenolate quite a lot. Most people feel a bit unsure about the value of those drugs. When you really look back into the studies that have been done, it's not 100% that's clear to me that the rheumatoid arthritis message about methotrexate necessarily applies in the same way. So there are trials, relatively small, relatively old RCTs showing methotrexate is effective for lupus arthritis, yes. But the trials that use things like azathioprine and mycophenolate, like I say, the majority of the patients in them had MSK features. And so if those patients get a global response, it's quite hard to imagine that happening if these therapies weren't effective for the MSK features. And like you say, the one thing I noticed, I was reading old papers. This is when I did my PhD and I knew the EXPLORER paper from front to back. There's an interesting little aspect of that, which is that the study was rituximab against placebo, but the patients could have a background therapy that could be azathioprine, mycophenolate, or methotrexate, and they published an analysis where they split them into those three groups. So you can look at the placebo arms and compare the three drugs, and the placebo response on azathioprine and mycophenolate is much better than it was on methotrexate, to the extent that in the methotrexate treated group, rituximab was better than placebo. It could have been a positive trial. So again, most of the patients in that study had skin disease or joint disease. So, I think the data is incomplete, but I think the whole reliance on methotrexate may not necessarily be the only thing we should think about.
So it's interesting, you kind of say that we often underappreciate these symptoms clinically, that ultrasound can be useful for picking up the disease, but unlike rheumatoid, and unlike, I think many people think going for methotrexate first, we do have other options that may be better, that may be slightly less conventional that we think about. Do you think that's something different with the disease process? Do you think that we're kind of stuck in the mindset of thinking, well, if it's an inflammatory arthritis, it's a similar picture to rheumatoid, or is there something different going on?
And that was the question I asked one of the other speakers, and I think we both agreed that we're not 100% sure about this, is that if you get MRI imaging on lupus joints and RA joints or other inflammatory arthritis joints, is there something really actually different going on in these diseases? Is it anatomically different with the structures that are involved, or which joints get affected? Or if you had synovial studies, can we see something different about the pathogenesis of the disease? I think you probably can. There was one a while ago that is quite old, but these microarrays, and interferon signature comes up in the lupus joint more than other diseases. But it needs revisiting that about what is pathogenically going on in lupus arthritis compared to rheumatoid.
And then looking towards the future, you kind of said that we need to think about studies in perhaps a slightly different way going forward. So what kind of ideas do you have?
Yeah, this is again. So if you think, we say that it's very, very difficult to do trials in lupus, but we know that we can do them really well in RA. So we should be learning from that. And so one of the things I've done with some of the studies we've done is try to think about how we can transfer methods and research methods from RA into a kind of a lupus trial. So we did something. So one thing, for example, is we developed, so the current outcome measures, the SLEDAI, it just says arthritis, yes or no, that's it. It's clearly not going to be the most sensitive tool to measure whether a drug's working or not. It's not going to get going to detect a patient getting 50% better or even 70% better. BILAG is better, but it still has some limitations. So we developed a tool called the Lambda, which is like a kind of DAS28 for lupus. It's a similar idea. It's a composite of a physician VAS, but just for the MSK features, a patient VAS just for pain, and swollen joint count, and an acute phase marker, and there's a formula. And so you can use something like that. And then the other thing you could do is, so imaging's great for defining active disease. So you can do an inclusion and exclusion criterion based on imaging. So we know it's really active. And then your randomization, your follow-up schedule, particularly your standard of care and how you control steroid use. If you focus on one organ manifestation, these things can be a lot more tightly controlled. So we tried to design a sort of a model study of how you might do a lupus trial that just focuses on arthritis, which is called ROOTS, and it includes all of those features. Well, we finished it. I don't have the result yet, but it's still an analysis. But so next year when I come to EULAR, you can interview me about that.
Excellent. Yeah, I look forward to hearing about that. And kind of one final question is with rheumatoid in the UK in particular, we have approach of we go with our conventional DMARDs, and if disease is active, we then move on to the biologic agents. With lupus now starting to show some promise with some biological agents coming through trials, do you foresee a future where we start again with a conventional DMARD and then move on to biologics in refractory patients? Or do you think that we need to think again differently to rheumatoid and perhaps introduce biologics sooner in patients with
I think that's right, isn't it? Because the pathway by which you get to a biologic in lupus is quite unclear, isn't it? Because you've got hydroxychloroquine and then belimumab and anifrolumab that are licensed and all the stuff in between. It's quite unclear what sequence you should go through these things, how often you should try them. But I think you're probably right that the general rule that introducing your best therapies early is going to be the right one. I mean, and this isn't just about arthritis, actually, it's lupus in general. But a feature of lupus is that the worst disease is in the first year. So in RA, actually, the whole early treatment paradigm was that actually things look quite subtle in the first year, but it's heading in a bad direction and you have to be. But it's actually in lupus, the case is more obvious because people get their worst disease and most of their steroid exposure in the first year. And actually, if you treated that better, you could probably put them on a better trajectory for the rest of their time with this disease, and that's a general message. Yeah.
Great. Well, thank you very much for speaking with me about that. It's definitely given me a lot of things to consider when seeing patients with lupus with joint involvement. And I think certainly thinking about those conventional DMARDs and also ultrasonography are things that will change practice, I think, on a fairly day-to-day basis. So thank you very much for sharing your thoughts with me, and enjoy the rest of EULAR.
Thanks very much.
Thank you.